So good afternoon, everybody. I think I welcome all of you for the monthly program of Indian, they organized by DCCC Center Climate Change and Exit Education Trust. And this month we have the program called Promoting TB Awareness through Community Engagement. So in this context, I request our founder of this institution in the absence of Satish, Professor Satish, J. Srinivasan. He was the founder of this institution 13 years ago, and he did IIT training in Chennai, then New York University MS, and Stanford is a PhD, and many years he has practiced there. And he has many editorial things and the IPCC reports. And climate change and all this is one of the authority in India. We are proud to have him here. And a man with vision, and also always encourages the learning process and academics and all those things. In addition to the man, he practices what he preaches. Why I say that, I always say this one, but what United Nations Environment Program says, each one of us have to reduce 2 ton carbon footprint per person, each one of us, to keep the temperature 1.5 degree at the end of the century. So he literally does it double the amount. He walks from here to his house. That one, I was totally vegetarian, and what he takes, other thing is a limited amount. All this he comes about to nearly saves 4 tons of carbon dioxide per person. And in addition to that, many of them are aware, you are not aware. And his uncle, none other than late Nobel laureate Sir C.V. Raman. And we have great pleasure always calling him. I request him to officially welcome the chief guest.
Good afternoon. Welcome you all to the monthly program on health that Dr. Parmesh has organized for the past now 3rd year under COMHAD auspices. And today we're going to hear about tuberculosis, which is an endemic disease in India. I think all of us have it. I don't know how many of you have got yourself tested. And as you get older, it comes up. Your immunity goes down, it comes up. And as a matter of fact, I wish the government of India would ask every person above 60 to get tested. I mean, because my experience, I've seen that many people are not aware that they have tuberculosis. They can't believe that they have tuberculosis, but it is coming either from milk or any other source. So I'm very happy that Dr. Parmesh has organized this program. I hope the awareness is created among all people about the need to test, because India is one of the leading countries in tuberculosis incidence and also death. And I remember the National Tuberculosis Institute, because when I was in school, I used to go by cycle from here in Valikaval all the way to Cantonment, and every day went past NTI, and always wondered, it was a nice campus, and the building was deep inside. From the gate, you cannot see it. So I'm happy that the director of the institute is here to tell you about tuberculosis, along with epidemiologist Dr. Vineet Chadha. So I'm sure all of you learn a lot of things. I hope you will propagate this information about TB in India to a larger audience, because to me, if you want to become a developed country, you need to bring down the incidence dramatically. Government has done a lot. Not government has not done it, but the incidence has not come down at the rate it should come down. I think we are probably next to Africa in per capita incidence, right? Which is not a good news. But partly, I think it's lack of awareness. So I'm very happy Dr. Parmesh has invited 2 eminent people. And so I request him to introduce the speaker.
Professor Srinivas, thank you, sir, for welcoming the guests officially. And I have a great pleasure welcoming all of you and Professor Somshekhar N. and Dr. Vinit Chadha for this program, promoting the community engagement in tuberculosis. And just to sensitize the certain issues of the background of this one as a program, introduction remarks of some of the remarks on the tuberculosis. March 20th is designated as the World TB Day because on this day, in the year 1882, Dr. Robert Koch discovered the Mycobacterium tuberculosis. Our aim is to propagate the knowledge to public. The prevalence of tuberculosis in India has been, some of the reports says 195 cases per 1 lakh population. The incidence, prevalence incidence, little confusion always, it does happen. The incidence of TB is 167 cases per 1 lakh population. Believe me, Delhi had the highest incidence and Gujarat is the lowest incidence. 5% of the TB patients have HIV positivity. Nearly 10.6 million people fell ill with tuberculosis in the year 2021. 1.6 million people died in tuberculosis in 2021. 74 million lives saved since 2000 by the global efforts to end tuberculosis. The multi-drug resistant tuberculosis is 9.11 lakh population, 2.3% among new cases as on March 2021. It is heartening to say that 18% decline in tuberculosis infection in India, better than the global average of 11%, but our regards to the health warriors. I think all over the world, 11% reduction. Ours is 18.7%, better than that one. And health worker department working beautifully, sir. We are proud of that one. This is a recent report. So ending tuberculosis requires concerted action by all sectors. Health system alone cannot be goal by ending tuberculosis. During the talk, the role of environment of the patient in the management of tuberculosis will be highlighted. And as you said, this topic is spoken none other than the director of the National Institute of Tuberculosis. And none other Dr. Somshekhar N. Dr. Somshekhar N. presently holding the post of the director of the National Tuberculosis Institute from the Ministry of Health and Family Welfare, Government of India, and also it's a WHO collaborating center dedicated to advanced research, tuberculosis, and training since April 2018. He's a pulmonologist and a public health specialist, and he worked as a specialist at chest physician at Crawford Hospital, Sakaleshpur, Hassan district, under government of Karnataka for five years. 2 decades of experience in the field of tuberculosis involved in the implementation of RNTCP in Hassan district of Karnataka. He joined the National Tuberculosis Institute as a TB specialist in November 2005 as a facilitator, master trainer of National Tuberculosis Institute. He contributed for capacity building of the district, national, and international TB control program managers. He is a national faculty of various conferences, member of National Technical Expert Group, Treatment and Diagnosis, Pediatric, and Ayush NTEP. Is a member of National Operational Research Committee, contributed for review and scientific publication in national and international journals. Chairman of the organizing committee, the recently held conference, the 77th National Conference of Tuberculosis Chest Disease. It was held in the 27th February 2023 and up to 1st of March 2023 by the JP Palace Hotel in the Convention Center in Agra. It is indeed very pleasing to see that the effort of engage of various community structures and TB survivors are getting due to importance under the clarion call of early 2016 to eliminate tuberculosis by our esteemed Prime Minister. The time has come to amalgamate all the recent efforts and learning in this direction into the more organized effort of delivery of tuberculosis care to the community with it and through the community. It will be also ensure that TB care service are not hampered in crisis situation like during the recent COVID pandemic. I feel that today's seminar is one such step in this direction. And also, we will, to discuss all this issue, without wasting time, I call upon our speaker, Professor Somshekhar. Over to you, sir. Thank you. Come, sir.
Great evening to be here in front of you. First of all, I can say Professor Parmeshwar sir as my guru also. And I have one more guru, Dr. Vinit Kumar Chadda. He is a globally known epidemiologist. Sir was, Srinivasan sir was just having a chart during the coffee. The incidence, annual risk of TB infection, prevalence of TB disease in India is the one who has done a national-wide survey. And his publications is more than 150 publications only in tuberculosis. Inspired by this one only, I am happy that when I called sir, we'll go to IASC, he came. Thank you, sir. After TB specialization, I also went for a public health specialization because of his inspirations. I am thankful to the IASC DCC. It's a great pleasure here. This year's Parmeshwar sir already mentioned about the importance of this World TB Day. Dr. Robert Koch is the man in Berlin Physiological Society. Yes, discovered, and he has shown that TB is not due to any karma. It is only because of the beautiful bacteria. That beautiful bacteria is killing all of us. It is going to kill. Is it the only medical services? As sir mentioned about that. It is the only medical people that has to do the fight against tuberculosis, because TB is not the only medical disease. It's a social disease, it's an economical disease, it's a family disease, it's a community disease. If I get infected with TB and develop a TB, I am going to suffer. Agree? Because the chronicity of the disease, by the time I diagnose, it may take 3 months. On an average, the studies have shown that on an average 3 months, my family suffers, my economy suffers, and on an average 100 days, I will not be earning anything. Along with me, my family member who is a caretaker also will not also earn. The family is going to get the catastrophic cost expenditure. Right. If I get the disease, my family members are also at risk. Then there are also chances of getting the disease is more. Economy lost, social disease, stigma. If I am having a TB, I will not get the match. The society, what it says that, okay, a TB family, his family may get the TB. No marriage. If there is a young girl in the family, they don't. And if there is a stigma is such that even if you diagnose that, they will not come to get the treatment also. In this scenario, as a being a doctor, if I give only treatment, is it enough? No. Any program, especially this chronic disease TB, it is considered as a social barometer. Without the involvement of the community, it is impossible. The polio we are able to eradicate because of the community involvement. The polio is only once in a year 2 times, if you give 2 drops, that's enough. But we don't have any vaccine or we don't have any drugs to give like that. Only early diagnosis, a prompt treatment is the only mantra. For early diagnosis, what is important is awareness. This World TB Day that is the reason that every year we have to create awareness. This year, the theme for the World TB Day is yes, we can end TB. The reason being, we were discussing with our faculties during the coffee hours. We were telling that what is the impact of COVID? COVID has impacted a lot. In 2019, whatever we have achieved, in a sense, an example, 24 lakh cases notified. It has gone to 18 lakh per year notification in 2020. However, the last year, whatever we have achieved, around 24.2 lakhs, we are able to notify to the program. Is it that? No. The estimated the TB cases are in the community maybe around 30 lakhs. There are so many cases, so many big number of cases not diagnosed. All these things is only possible with the help of the community awareness, community engagement. Without the community involves everybody here, outside, family, everything involves everything. What are the program is doing currently? Sir was mentioning India is the #1 country. Yes, if you take the quantification, if you take the prevalence or the incidence, it is always high TB burden countries are there. Out of high TB burden countries, high TB burden, also high HIV TB burden, and also high MDR TB burden. Out of all these 3 high burdens, India is there in that triangle. If TB is controlled in India, globally, TB can be controlled. That's what it says that. So India always have innovations, bigger interventions to adapt to these situations. What has happened in the last year? The governor of honorable governor of UP, she has adopted some TB patients. Adopted in the sense it is a support given to the TB patients, pediatric TB patients. Taking a cue from that, the president of Honorable Her Excellency Srimati Draupadi Murmu ji, in September 9, 2022, she has launched a program called Pradhana Mantri TB Mukt Bharat Abhiyan. Here, it is a mass movement for TB elimination. We can say that anybody, any individual, any political party, or any NGOs, or any cooperative society and corporates, including the universities and colleges, being students, being the staff of the colleges, faculty of the colleges, around 102, if you come to the colleges, around 102 institutions and universities have signed. In that, already 2,300 TB patients they are supporting students and colleges. What they can do, yes, being a doctor, we provide the drugs, but it is a additional support to the TB patients. What we can do is a nutritional support, vocational support, or any for investigations, additional support investigations also we can give. Just to say an example, an honorable Rajya Sabha MP, Layar Singh is there from Karnataka. He has motivated and inspired 1,500 TB patients he has adopted in different regions of Bengaluru. Not only that, he has inspired and he has provided a handheld X-ray and a gene expert mission along with that. Apart from that, An individual for a 6 months treatment period, every month, you can always provide a nutritional support to the TB patients. There are two types of food baskets are there. What is required is for a TB patients, cereals or a millets, pulses, vegetables and groundnuts, protein, and vegetables and fruits, vitamin, or a milk or a egg option is there. Two types of baskets every month for the period of 6 months you can give. There are different mechanisms. As on today, what has happened? Around 13 lakhs TB patients are there on treatment. Around 10 lakh TB patients consented, okay, I am ready to take the donations. 60,000 TB Nikshay Mitra, we call them as a Nikshay Mitra. Mitra means one who helps or supports. What they will do, they will register in the Nikshay, they become a Nikshay Mitra, they will get the OTP and whatever the amount they can give, it is not the amount, it is the patients or it is the block or it is a taluka, state, whatever it may be, they can support. They will be linked by the district TB officer. The mode of, there are three different modes in Gujarat they adopted. One is the person who is a Nikshay Mitra can give the money to the mart, DTO identifies the mart will supply to the TB patients because stigma is there. The other mode is the DTO identifies a NGO somewhere, NGO is there, you can give the money to NGO or NGO will distribute the food baskets. Otherwise, directly for the Nikshay Mitra, DTO assigns, okay, these are your patients. You can directly go and give the food baskets. Why these food baskets are required is the most common cause for TB social determinants. You can say that undernutrition, alcoholism, and then the smoking, uncontrolled diabetes. These are the comorbidities. If you take undernutrition is the one which is the major proportion that gives. 45% of the cases are attributable to this. If the patient BMI is less than 18.5 during the treatment, the chances of outcome getting cured or treatment completed is very low. However, if you provide this additional nutritional supplements, the treatment outcomes can be better. That is the reason this nutritional supplementation. This is nutritional National Institutes for Nutrition. There is a institute is there in Hyderabad which has provided this one. The another initiatives for the engaging community is TB Mukt Panchayat initiative. To make a TB Mukt Bharat, you have to decentralize and each and every panchayat or a grama panchayat, whatever we call, that local governments has to initiate. One is what the program does is sensitization of the PRIs, elected representatives, community leaders, and then they are going to help anybody who is having a symptoms for the diagnosis and they support the treatment services and sees that they complete the treatment. The major problem is we are discussing that, yes, we start the treatment, but very few complete the 6 months course of treatment. The reason is simple. I am symptomatic. When I get the diagnosis, yes, when you say TB, I will take the treatment. But my symptoms after 2 months disappears because a sputum culture to get converted into a negative, it takes 6 to 8 weeks. By the time I take the first initial 2 months, my symptoms goes down. Then another 4 months without any monitoring or supervision, I will not continue because I don't have any symptoms. Why should I take? Because these drugs are not the sweets or a Mysore pak to take every day. Adverse effect also, we have to tolerate that and we have to counsel the patient that they complete 6 months. Otherwise, relapse is going to happen. Treatment relapse is going to happen. There is a chances of resistance and failure. This is the one, the 6 months period we have to follow. For that, community support, family support is also required. These are the steps that Gram Panchayat has to take. That yes, they have to voluntarily, after getting trained, and they have to make a task group, task force there. They have to monitor the TB patient. They have to support and see that early diagnosis and complete treatment happens. It may be economical support, it may be mental support, emotional support, everything is required, and stigma mitigation is very, very important. You should not stigmatize any TB patients or the family. Kshaya Mukta Grama Panchayat activities with the NGO support, Government of Karnataka has taken an initiative. They build the capacity, they align with the TB activities, task force has been formed, they have a Arogya Amrut Abhiyan, and they follow Kshaya Asare, that is additional support, and there is a quote, TB Solisi Grama Panchayati Gellisi campaign. Active case finding also they are helping. Yes. Is only a department or the Ministry of Health and Family Welfare is enough to control the TB? Eliminate the TB? As I told you, it's a disease of the society. It is a disease of the community. Yes. Other departments are also important. Other ministries are also important, line ministries. So it's a multi-sectoral corporate engagement is also required. Yes, when we say corporate or factories or industries or any institutions, awareness generation, early identification of the disease, and integration with the TB services, care services, stigma and discrimination reduction, and social protection. These are the principles for multi-sectoral engagement. There are 23 line ministries, we call line ministries, associated with this health disorder, disease. Out of that, each and every ministry has a different roles. If you take Ministry of Panchayat Raj, has already told that they have to sign, already sensitize the Gram Panchayat, Department of Internal Security, Ministry of Ayush, National Highway Authorities, Tribal, Railways, Defense, so and so on. Because health is not only provided in our country by only Department of Health and Family Welfare. Defense has got a different health system. Railways has got a different health system. Like that, all the people in the country should get that support. When it comes to the corporates, just to mention, TB, we discriminate the TB patient, TB families, but TB doesn't discriminate whether you are poor or rich. I studied my post-graduation and undergraduation in Mysore. Mysore Maharaja's sister, Rajakumari Krishna Jamani, she has suffered from tuberculosis. Otherwise also, they are very philanthropist. They have donated 80 acres of land and a sanatorium has built. If you might have gone through KRS, Vrindavan, from Mysore cities to there, it was away from the city that time. Where? Why Princess has developed TB? Anybody. It need not be a poor person. Anybody can develop a TB. It doesn't discriminate. Corporate sectors. Yes, these corporate sectors are also as a CSR responsibility, and also they have to protect their own working people. They can create awareness and also on diagnosis and treatment and counseling. Not only that, they can engage the communities, their family members, working family members, or they can choose certain Gram Panchayats or sectors, whatever it may be. There are more than 20 lakh people already educated, facilitated on this. They may be helpful in providing the equipments for diagnosis like mobile x-rays, mobile laboratories, so on and so on. These are the ones different. This one has given the best corporates and industries they are involved in TB. Right. Somebody has to monitor all the activities, TB care services, as well as the community. Who is going to monitor? Who is the best person can monitor? I am a TB patient. I know my sufferings. I have suffered. I know. Then who is the best? A person who has suffered from TB and cured and ready to share and ready to take the responsibility, helping other TB patients. So the best person is the person already treated and cured person. They're the main pillars. We call them a TB champions. If they are ready to spare their time, if they are ready to help other TB patients. They are there at the local level. They are ready to support the families for referral linkages, where the treatment is there, diagnosis is there, and then how to give the treatment, and mentally supporting, emotionally supporting. And they should be trained and they are ready to spare the time. They are the TB champions. In each and every block villages, they will be there. We are going to identify, they are willing. Very important is they are willing, because TB patients already stigmatized. If they are not willing, difficult, we don't take them. These TB champions are trained and then they will take care of the responsibility. In the block level, block TB forums are there. In the district level, under the leadership of administrative control of the DTO and DC, there is a district TB form and state TB forms and national TB forms are there. It is the only TB patients, civil societies, corporate sectors, administrators, and different members from the other line ministries, because they are also responsible for that. They form this TB forms. They are the one, the program is going to listen. What are the gaps? How to make more acceptable, more feasible? What are the challenges they face? To form any guidelines and policies, we take their help, we incorporate. Representation is there from them. It's a platform for the TB patients and other community volunteers or NGOs to take care. There is one more, patient support group is also there. They need not be a TB patients. In the bottom of what I told you, TB champions means always a TB peer group, treated or cured TB patients, but patient support group, other community volunteers. So this is an institutionalized mechanism for community engagement. Yes, to mitigate the stigma, to reduce the stigma, to see the patients complete the treatment. This is the platforms. As I mentioned, TB Vijeta is a TB champion, media, local NGOs, key influencers. It may be faith healers, local religious leaders, and line ministries and civil societies. Treatment support, referral linkages, peer counseling, and advocacy. These are the main roles. How to find the TB case? Where to find the TB case? All primary health centers, beyond that, Ayushman Bharat health and wellness centers are there. In the sub centers, we have changed to Ayushman Bharat health and wellness centers. There are more than 1.25 health and wellness centers are there. Now the structure is, they are the bridging the gap between the community and the primary health center. They are the graduates, science graduates, mostly nursing students or physiotherapy or other health related graduates. They will be placed at the sub-center. Sub-center is around 5,000 population, one sub-center will be there. Primary health center is around 20 to 30,000 per population, one primary health center. There, not only TB, they take care of other things also. They will be referring, we have 4 symptoms of TB. Anybody who is having a cough of more than 2 weeks, fever, evening rise of temperature, cough with blood vomiting. What I mean to say is when they are coughing, it is hemoptysis, not the vomiting. Vomiting is different, I'm sorry. Hematemesis and hemoptysis. And then when they are having loss of weight, loss of appetite. These are the main symptoms. For them, they have to be referred if they are having a cough with the sputum. Sputum will be transported and the patient will be going to the place where these diagnostic facilities are there. It may be a block level or a taluka level. We have at the PHC level, we have a smear microscopy, or otherwise when they suspect clinically, they will be referring to the block level hospitals where X-rays are there or CBNAT machines, molecular diagnostics are there. Or to reach areas, tribal population, that is the reason Ministry of Tribal Affairs also is there. There, the mobile X-rays will go, mobile laboratories will go, they will screen and they will diagnose the TB, the sputum. Again, at the, they call at the sub-centers level, I'm sorry, sub-district hospital level, sub-divisional hospital levels. At least TrueNAT mission or gene expertise there, that is a molecular rapid diagnostic technique. For smear examination, Zn smear, what we call, the level of limit of detection is around 5 to 10,000. However, this gene expert or TrueNAT around 130 colony forming units are required. Once diagnosed, they will be report will be sent, and it is not, it detects 2 things. One is MTB detected or and whether rifampicin resistance detected or not detected. MDR-TB, what we call, right? Because there is a different regimens for this, drug sensitive and drug resistant TB. After that, they will go back to the this one with the results in the PHC in the nearby their health centers are there. Where the home residency is there, there are treatment supporters are there and dot providers earlier what we call. The medical officer will identify and there they have to take under direct supervision the treatment. Not only that, there are high risk populations are there. For example, alcoholic, undernourishment, those who are smokers, HIV. These are the places, they are high risk. High risk in the sense compared to general population, their risk of developing infection as well as disease, breaking down disease is very high. Systematic screening happens there. That is intensive case finding. And every year we have a program that we are going to the community for active case finding. Intensified case finding and passive case finding, the doctors at the health facility, they will do that. However, for the active case finding, the health workers, health force will go to the community. They actively ask for the TB symptoms and screen, identifies the cases. There is a daily regimen 6 months. Earlier it was 1 year, 1.5 years. Now it has been reduced. Even for drug resistant TB also 24 to 27 months is there, now 18 to 20 months. And 50% of them require only 9 to 11 months of treatment. We have a newer drugs, bedaquiline. Now, everybody, most of them will be having what I mean to say is 90%, I can say that. Mobiles with IT enabled, okay, smart mobiles. Because of the stigma, some patients may not take the drugs in front of the other neighbors are the healthcare workers. In that case, they can take, there is a system in front of the mobile video adherence, or there is a mobile, there is a number is there linked with the patient, just rings that, it will go to the software, the patient identified patient, it shows in the dashboard whether the patient has taken treatment or not. And next thing is comorbidities. Comorbidities, diabetes, HIV is the major risk. All TB patients diagnosed will get that test, RBS and HIV test. The other way around is also there. Those who are diabetics and HIV, they also has to be tested for TB. Once the patient is registered or notified, he will get direct benefit transfer. That is 500 rupees will be given to the patient account or the patient relative account every month for nutritional support by the government. And then for tribal area, 750 rupees, tribal support is also there for transportation. COVID has taught many things to us. One is the diagnosis, after that we get a treatment. What about the mortality? In certain groups, the mortality is very high. If you take TB itself, it may be more than 35 per lakh population. How to reduce that? We have to reduce the TB mortality also. The reason is COVID, you just remember that mild, moderate, severe. We have some criteria, differentiated COVID care. Those who are severe only used to get admitted. Those who are mild, okay, you go home based. Those who are moderate, okay, wait. There are certain centers, CC centers over there, then they used to shift to that severity or to the home based. Like this, we have a different models already adopted in Karnataka and also Tamil Nadu and other states also. It is called differentiated TB care. What it does is they check for around 5 to 16 parameters. In that, if the score is very high, they will be referred to the tertiary care center or secondary care center where the patients will be admitted and treated and sent back once they reach the benchmark. In the sense, severity of the disease also plays a major role. The severe disease requires admission, non-severe not required admission, home-based care. That has reduced the mortality. This is what it has shown in the field conditions. The other intervention that is very, very important is TB infection. In this group, in this audience, if you just do the TB infection test, that is a Monto test or CYTB test, IGRA test, what we call, all are going to be positive. I am strongly positive. Dr. Chadda sir is, Parmeshwar sir is also positive. What about you youngsters? You are also positive. Okay, don't scratch your heads. Director of NTA is telling that I am positive. You are positive, but so far nobody has cough. In the sense, you are infected like us, but not diseased. Diseased persons will be having a signs and symptoms. Diseasiness is there. Infection, inside, the bacteria is there. So immunity and bacteria has fought. So our immunity is strong. That's why the bacteria has been contained. Till our immunity is strong, the bacteria will be there inside. If our immunity goes down for any other reasons, the bacteria will explode. That becomes the disease. If I get infection today, I may get the disease within 6 months or in my lifetime. The infection is there. All infected will not break down into disease. So you need not bother. An example, 100 infected population, if you take, 10 will develop a disease. Out of that, 5 will develop a disease within 2 years, another 5 in their lifetime. Okay, so how to do about this? But TB infection breaking down into disease is more among certain population. What is the TB infection rate in the country if you take the prevalence? Around recently concluded study has shown that it is around 31.5% of the population. But if you take the family members of the index cases or TB patients, it's up to 75%. Like COVID, an example, just to mention that if one person is there, COVID patient in the family, whole family will be screened. It's a family package. But it is only infection, not the disease. But these patients has to be followed for 2 years. We will wait whether they develop the disease or not. Before that, you test them. You test and give the chemoprophylaxis, such that breaking down into disease also can be brought down. 35 to 40 million population are already infected in our country. We cannot give treatment for all. Those who are high risk only, contacts of TB patient, pulmonary TB patients, pediatric population, and also undernourished, diabetic, and mainly those who are people living with HIV. These are the people that we give chemoprophylaxis. And DRTB households also we have initiated. Only problem here is 6 months of taking treatment in the absence of symptoms is very difficult. For the pediatric population, less than 5 years, plus people living with HIV, without any testing, we will give the chemoprophylaxis. For others, we test. If they are positive only, that we give chemoprophylaxis. The reason is we can 60 to 90%. But the protection, how many years? 6 to 19 years protection is there. In the absence of vaccine, this is the one which can reduce. Sir was mentioning 18% reduction. 2015 to so far, 2021, 18% reduction. It would have been every year. Globally, it is 11%, but India is more compared to the global levels, but every year 18%. Then whatever the Prime Minister has told that we can end TB by 2025 would have been, that is ambitious goal we would have reached. Now shorter regimens, that is weekly regimens are also there. Then we have private, 50% of the patients will go to the private sector. That's what it has been observed. And also it has been shown that in the recent prevalence survey, some people may not be having any symptoms, but when we did a X-ray among high risk, there we found some chest X-ray lesion, and then when we subjected them for, we are able to diagnose 50% of the cases. It's just a survey, whatever the research mode we have done it. Probably in the initial part itself, we can diagnose if we have a chest X-ray. And for example, as TB bacteria doesn't differentiate, the program doesn't differentiate whether the patient takes the treatment at the private sector or the public sector. For everybody, treatment, drugs is same, standard and free of cost, including context investigations and support, counseling, whatever it may be, DBT, TB Mukt Bharat Abhiyan, TB Nikshay Mitra, all are, they are involved. But when they go to the private doctor, they should notify. That is very, very important. The drugs are also kept at the private clinics if they are not willing to come to government sector. Always crossover happens. Pre-availability, fixed dose combinations. There are 4 drugs are there: INH, rifampicin, pyrazinamide, ethambutal for 2 months, and then pyrazinamide will not be there for another 4 months. Why we have to give the fixed dose combination? The reason is there is a selective, the red beautiful colored rifampicin patient will take, others he may not take. So fixed dose combination reduces all the drugs patient has to take and will not. There is incentives for private providers also. And we have collaborations with the professional associations. If they give a treatment, the incentives for private providers initially 500, and then After completing another 500. 500 rupees is less for the private practitioners. They need not bother. They can assign a nurse, at least an attender, hospital or clinic attender to that. At least they will get. They can monitor because the only treatment monitoring has to be done and counseling and see that patient completes the treatment. There is a treatment supporter or DOTS provider. It may be ASHA worker, Anganwadi worker, or anybody in the community who is ready to give the drugs under supervision, because patient himself will not take. Somebody should be there. Only family DOT provider or treatment supporter is there for a pediatric population. For the stranger, the child will not swallow in front of that. Otherwise, everybody identified TB patients, they should take under somebody who is also a treatment support group. For drug sensitive, 1000 rupees, or DRTB 5,000, and for TPT completion, 250 is there. If somebody informs, yes, notifies, maybe a chemist or a laboratory technician or a laboratory, they will be incentive for 500 rupees for that. Travel support for the tribal population. Right. The determinants, when we told that without the other ministries and other community, we cannot succeed. That is the reason for undernutrition, smoking, alcohol, diabetes, HIV, they contribute to around 45% of the incidence. Say, for example, around 24 lakhs are there, around 11 lakhs because of these determinants. Yes, no tobacco clinic is there. There we have to counsel. There is a collaboration for them. RBSK is there. NACO program is there. Poshan Abhiyan is there. So everybody has a collaborative activities. All the other ministries also. This is what I was mentioning about Ayushman Bharat Health and Wellness Center. There, every month, there will be a meetings. Mahila Arogya Samitis may be there. NHSND is there. Nutritional Day is there. Like immunization day. There they will be having a community meetings. They can disseminate, and we have a CBAC form, population-based screening. Is it only for the TB? But the program is there, health program is there for identifying other diseases also integrated. Now the glucometer is there, BP apparatus is there with them. They screen the population. They identify early diagnosis and other infective diseases also. And there is a telemedicine. Using artificial intelligence or a telemedicine is we have utilized in the program. For example, X-ray has been taken at the block level, but the radiologist is not there. Radiologist is there here. In Bangalore, we get that. What about the rural areas? So for that, if they send the X-rays, there is artificial intelligence, it is validated, it gives the results. What required is whether X-ray is normal or abnormal, that's all. If the report says that abnormal, immediately the sputum examination will be taken care for that patient. Because microbiological diagnosis is very important. And also it is near to the community where they can work better. Best accessibility. Accessibility is very important. And every year there is a thematic month, or in that particular month they do active case finding. How to identify? This is an op yuga. Everybody will be having ops for everything. Okay. In that there is a TB Arogya Sathi. Where the test is available, you can identify. Where the treatment has been given. Or we have national call center also. It is called Nikshay Samparka. So where counseling, adherence, grievance redressal, TB notification, information, all those things with different languages, we can have that. You can call always. This is artificial intelligence for X-ray diagnosis. And also there is an app, it is piloted, where if you just cough in front of the mobile phone, smart mobile phone, it can tell whether it is TB or not. It is under piloting. Laboratory results. There is a molecular diagnostic strips are there where line probe assay. where it can also, it is under process. It can tell that after feeding that whether it is resistance or not. There are 4 pillars for the TB control: prevention, detection, treat, and build. In the build component, yes, very important first part is community engagement. Without the community engagement, nothing works. Just to, out of all this, just we will see what is we have to know our enemy. This is the beautiful mycobacteria. Microbiologist always calls this, why I say beautiful, is a pink, slender, curved bacteria. But it is not only beautiful, very intelligent. It is since immemorial, it is there. It is going to be there. It adopts whatever the medications we give, whatever this one, it is even with lot many efforts, it is changing its, this one adoption is very good at it. How TB is transmitted. Everybody knows this. How COVID is transmitted. Droplet nuclei. Here also, a person who one cough is enough to infect in this audience hall. In an INOX theater, you are watching a Life of Pi. You are so involved in that movie. One person coughs. You don't know whether he is having a TB or not. That one cough is enough to give TB infection to the all audience. Life of Pi becomes life of TB infections. So this is a photograph which shows that a cough. Can you tell me how many droplets it can generate one cough? The force 40,000, up to 40,000. One droplet is enough to infect. These are the determinants. Out of that, undernourishment is very important in our this. Now, there is a separate screening. In Anganwadi, if you remember, some children are there in your houses. There is a growth monitoring chart is there. In Anganwadi also, they plot the growth chart. If there is a grade 3 and grade 4, that is severe undernourishment, they will be referred to nutritional rehabilitation centers at the taluka level or district level. Grade 1 and grade 2 they manage. During that, TB screening is very important. They do. HIV infection, alcohol disorders and smoking and diabetes. These are the risk factors. And other overcrowding. The transmission is more among poor housing. We have in the cities, more migration is happening because of the industrialization and urban development, poor housing. And then tribal population migration, lot of migration we see. You see the overcrowding. These are the places where more transmission happens. These are the just some of the symptoms, very important symptoms. More than 2 weeks, with or without expectoration, cough. 2 weeks of cough without sputum production. Fever mainly in the evening. Loss of weight, and when the patient coughs, there is a spots of blood or blood may be coughed also. Loss of appetite, and there may be chest pain and generalized weakness. These are some of the symptoms. Just how to diagnose? Just sputum examination, ZN smear. Binocular microscope is there, where how it looks like that beautiful bacteria. And this is fluorescent microscope also, we can use that. Auramine, rhodomine, staining. What are the other molecular diagnostics? Yes, TrueNat, and then CBNat, line probus. This TrueNat and CBNat are the one which gives rapid diagnosis. Culture. Sir was mentioning ours is the only NTI laboratory, along with 3 laboratories were there, where this culture was done. Like agriculture, we are doing the TB lab, mycobacteria culture. But it takes around 6 to 8 weeks to grow. To get the resistance also another 6 to 8 weeks, 3 months. But the problem is by the time we get diagnosis, the 1/3 of the patients were no more. That is the reason rapid diagnostic step. We have come back to this NAT test, which gives within 1 or 2 days. Why 3 drugs are there? Because in the bacterial populations, we have different subpopulations. Extracellular rapidly multiplying, and then intermittently multiplying bacilli, intracellular as well as in the acidic environment, and dormant bacilli. There is no single drug which acts on all this population. That is the reason a group of combination of drugs we have to give, because each and every drug act on a different population. INH and rifampicin rapidly, and also streptomycin injection. Now we don't have an injection. Now we have injection free regimens. And rifampicin also acts on the intermittent bacteria, and also pyrazinamide acts on the acidic this one. That is the reason during in early inflammation only we give pyrazinamide. After 3 months we don't give. There is no drug acts on the dormant bacilli. That is the reason still we have relapse. We can get the relapse. 4 drugs 2 months. That is 2 months in the sense 56 doses and 112 doses for another 4 months. This is how the drugs looks like. In front of somebody they have to consume. Once the doctor prescribes the medicines, this is a process how it goes. Treatment card will be opened, it will be monitored, a DOTS provider or treatment supporter will be identified, and then a drug boxes will be handed over to the treatment supporter, and weekly supervision will be there by the health workers. But 6 months after giving treatment, we will not stop, because there may be some adverse effects. We have to monitor for adverse effect and progress. Initially smear positive, at 2 months whether smear negative, or grade 3 is there initially, whether the load has reduced, and then another 4 months. At the end of 2 months and at the end of 6 months, we do smear examination laboratory. But every month medical examination is a must for weight increase, any adverse effect, and physical examinations. This is about the management of TB and community engagement. Thank you for your patient listening. I am happy to take any questions. I'm sorry, another 15 minutes extra I might have taken.
I think we are going to have a picture, so everybody has to wait here before we go. And Professor Chadda is also there, and any questions we can able to answer that one with pleasure, sir. Any questions, sir?
Yeah, long distance air travel is supposed to communicate, right?
Come, sir.
Long distance air travel. People go from here to US.
Sir.
They claim that because you're there a long time in the aircraft, you can get tuberculosis.
Sufficient.
So what is the probability?
Sir, chances is there, sir. Sufficient time, sir. In the sense, when we say close contact or household contact, household contacts will be breathing the same air, sir.
Yeah.
Close contacts in the sense, sometimes I may visit that person, he is my relative.
Yeah.
One day is sufficient enough to get the transmission.
So when you travel 20 hours with
It's a closed compartment.
200 people, the chances are very high, right?
Sir. It depends on the immunity also. Sir, you want to add something?
Yeah.
It depends on the immunity of the person getting infected.
I was, telling our Delhi people that in the inter-ministerial collaboration, you should also collaborate with the Ministry of Surface Transport and Civil Aviation and like that. Like, air hostesses make announcements. There's a safety routine and all. Why not tell them that while coughing, you cover your mouth? Similarly, we have no smoking billboards in the buses and trains. So I was telling that please have them in train and buses as well. Tamil Nadu started doing it.
Okay.
So in Chennai specifically, and I was briefly in Tamil Nadu, And this was initiated by our National Institute of Research in TB. So they trained all the conductors, and they were distributing some pamphlets also to TB patients. It was not happening. Fortunately, COVID came, so I thought cough hygiene and behavior will improve. But after COVID, restrictions have gone. It is all back to the same.
But in terms of BP went down during COVID?
I'll come to that.
Okay.
So the person sitting next to you, again, the sneeze and just like that, chi, and it is happening error prone. But your question is very valid. Yes, definitely. Lot of TB transmission must be happening in aeroplanes, but we don't have a way of, no study has been done how many people get infected because it's not feasible study. Now, COVID, what happened? We were using masks, but we were not using mask at home. And most of the TB transmission occurs indoors at home. So TB did not, the mask did not prevent COVID. And then what happened during COVID, because of the lockdowns, people were not going to seek care. So as he told, annually in 2019, we notified under the program something like 2.2 million or 2.4 million cases. But it went down at one point, 61% down. Overall in 2020, there was 25% reduction in diagnosis. So the cases were not diagnosed, they kept transmitting the infection to others. And now we are seeing an increase in cases in Karnataka. That's a different thing that we have given the award. But, everywhere now, because in 20 and 21, those who got infected, now they are breaking down to TB now. And you are seeing an increase. So COVID has led to increase in TB. That's short answer to
How about the AC train? People travel
Closed compartment.
28 hours
AC
all
is
the way.
not good.
Huh?
See, to prevent TB, every room,
Should be
there should be at
Ventilated.
least
No, but
1
not
hour.
in AC, yeah.
I'm telling you, any room.
Right.
In one, you don't know who is a TB patient, who is coughing. So every 1 hour, there should be 6 air exchanges if they have to prevent TB transmission inside.
Right.
And in high transmission setting like TB laboratories, there should be up to 12 air exchanges per hour. So AC is not at all good. AC promotes transmission.
Sir, just to add on to what sir told, sir, actually, in one of the HIV clinics, ART centers in Kozol, Natolo, all are infected. That's the reason. It depends upon the immunity. Those who are sitting, only one TB patient was XDR TB, that is XDR TB. One patient coughed and all got infected there. Out
Yeah.
of
So
56,
only
54.
only silver lining is that TB is much less infectious than COVID.
Yeah.
If in a room, if COVID, so one of us is having COVID, 70% will go back having COVID disease. But if we are here for an hour or so, maybe 1 or 2 may have, you require a little prolonged contact. Other is that COVID means if one is infected, almost everybody gets the disease, or at least 50-70%. But TB, once you get infected, only 5 to 10% get active TB disease. Our immunity checks the organism and we don't get it. So that way TB is not, transmission is not as scary as COVID, much less scary.
Yes, sir. Thank you, sir.
Thank you for the amazing talk. You spoke about the video period drug, right? So just 3-4 days back, there was this news saying that Johnson and Johnson's patent for the drug has been rejected by the patent office. So do you think that this will have an impact on the drug quality manufacturing for this drug in specific, or it's like a win-win situation and the drug will become cheaper and more accessible to all?
So far, what the guidelines was given is the government of India has only given, it is not under the private, it is only for the program, under program only. Only program procures because it's a drug resistant TB only, because it's a very important drug, reserve drugs. So far, but the private practitioner, if he treats, it is not available in the medical stores. If you go, even private doctors, if I write also, they don't give. It is only the program procures and distributes to the patients. That is number one. Regarding the patency and other things, whatever it was came in the media, yes, I do agree. There are certain challenges. And if more manufacturers are there, if there is a patency, only Johnson and Johnson can. Some companies, other companies they cannot. They have rejected this one because it's not a original. This one, it's only a salt preparation, something like that. That's what I also read there. Yes, if more players are there, certainly the cost is going to come down. It's a good thing for the more players. India is the number one anti-TB drug manufacturers. It supplies to different countries. So, the TB disease we have to take as a global problem, not only our problem. So, in that context, yes, you are right. More players should be there.
Competition will decrease the cost and they'll be able to export more.
Okay. So because of the time factor, I don't think you can entertain any further questions. But I take this opportunity to congratulate a wonderful talk given by Somsekhar and also interacted with Dr. Chadda. We are really lovely to have to them. And we request Professor Srinivasan give a token of appreciation for them to come over here and giving the talk, sir, for both of them.
Thank you so much. It's my pleasure.
Yes. Before the photo, we want vote of thanks by Sangeeta.
I would, on behalf of the Vecha Center for Climate Change, I would like to thank Dr. Somsekhar and Dr. Chadda for taking the time and sharing the insights and the knowledge with us here. And I would also like to thank the audience for giving their time here. So if we can all join for a photo session. Thank you.
We have everything easy.
Not in the room outside. When it comes back, it's very hot. But it does feel it. Otherwise,
What you can do is, for example, the radiology room is there.
yeah.
So you can do it when at the end of the day, patient can die. Right? Isn't it? Or you can do it that, there are different ways of doing it. So for example, when coughing patients are coming, you have a slot for them. And for other patients, you have that separate slot. And when coughing patients come, after that you do ultraviolet radiation, keep the room closed for 1 hour, and then invite other. It's very difficult, very challenging. And the effects of the eye, the bulb goes
Not
off.
in the room. I don't see the theater. As it's going up, you keep up and broadcast. They were not in the room. Outside.
Something like that, outside.
Again, in the air conditioning.
Outside.
The air conditioning system, that ultraviolet thing, that goes through it. This one, and how long comes back? How long does it take? The question is, how long does it take it to the factory? 1 second, 2 seconds, that's what I want to.
So in high transient settings like lab, microbiology labs and all, we have what is called as FO filters and negative pressure.
Yeah, that is remove the
But UVCI for that, they are not using it. But even in the cultural lab, we still have